Welcome to the very first edition of Ask an Endocrinologist. We have Dr. Manessis here from NYU Langone in New York. Yes. And to introduce him, give you a little bit more information, we have our amazing diabetic educator and his diabetic educator, Dr. Jean Chen. We're going to be answering questions for about half an hour. All about diabetes, all about taking care of diabetes, including the diet. So please introduce Dr. Manessis for us.
Well, hi, everyone. Thanks for having me back again today. I want you to meet one of my favorite people in the world, Dr. Anastasios Manessis. It is him who helped diagnose me correctly. It is him who helped me get my diabetes under control by proper diagnosis and putting me on insulin pump. At first, I thought that I was going to die in 10 years from diabetic complications, but thanks to him, I have hope. So let me introduce you to Dr. Anastasios Manessis.
Thank you, Jean. Thank you, Kim. Thank you, everybody, for letting me be part of your panel. It's a great pleasure. And if I'm a little bit nervous, excuse me. I'm not used to doing this a lot. Okay, but I'm very excited that we're going to spend half an hour and going together and going over any questions you guys have relating the management of type 2 diabetes and how, or even type 1, and what we can do really to prevent complications associated with that. So I'm all yours.
And I think that this is so important, and we appreciate you donating your time because endocrinologists are few and far between. What is it like being an endocrinologist and being one of the few across the country? We have some states that only have one. And what does this mean for patients?
For patients, it means that it's very difficult to find an endocrinologist. There are not a lot of them. Unfortunately, there is not a lot of push towards endocrinology because the management of diabetes has become very complicated. So a lot of people don't want to become endocrinologists because diabetes is part of endocrinology. It's the major part of actually. So patients, it's very difficult for patients to get access. If you have to wait 3 months and your sugars are in control, this is not, weight loss. This is really something that requires immediate attention. So you need to try hard to get an appointment with an endocrinologist as soon as possible.
Yeah, so many people just have to rely upon their primary care doctor, but there are limitations to the experience and what a primary care doctor can do for a diabetic patient. Is that correct?
That's true, but primary care are our gatekeepers. So without primary care doctors, we really cannot, we need them the same way they will refer us to a cardiologist when they have cardiac problem. They may refer us to an endocrinologist to treat the diabetes. Usually what should be done is the patient should go to see their primary care doctor, should be started on certain medications, going through a diet and lifestyle modification to help them improve their management. And after that, they, as it becomes diabetes, because it's a chronic disease, becomes more complicated, should be referred. And the idea here is you should be referred earlier before complications start, because when complications start, guess what? Then we're a little bit too late in the management of those complications.
Yeah, and that's the complications. That's what patients tell us all the time, that they wish that were discussed earlier, sooner rather than later. Most of the patients that now have ended up with PAD started out with diabetes, and they say, God, no one ever talked about it. No one ever told me that I was at risk of blocked arteries at my legs. I never understood the serious ramifications of even just having one extra sugar molecule floating around in my body.
That's 100% true. Unfortunately, we didn't talk about complications. And the reason why we didn't talk complications, because by the time we get diagnosed, it's probably, we already have a disease for 5 years, but we usually do not have any symptoms. When I say we don't have any symptoms associated with hyperglycemia, hyperglycemia means elevated sugars. It is later on in life, usually within 10 years where we start developing what we call small vessel disease. Like it starts affecting our eyes, it starts affecting our nerves, causes neuropathy, and the kidneys. And it is something that we have to monitor. And every year we should check, we should have an eye exam, we should have a podiatry follow-up, and we should also check our urine for protein excretion just to make sure we don't have any early damage to our kidneys. Unfortunately, when we start seeing that element of small vessel disease, that's possible then when we start developing what? Heart disease and what we call peripheral arterial disease, PAD, which needs to be, taken into serious consideration.
We have a question that's coming in from Sarah, and Sarah wants to know, what is the optimal A1C for someone who is type 2 diabetic versus someone who is type 1 diabetic?
There's no real difference being type 1 or type 2. What matters there is the type of the management. So what we usually, there's two societies that define the A1Cs in the United States. Okay, one of them is the American Diabetes Association. They recommend an A1C of less than 7. And there is also the Association of Clinical Endocrinologists, like endocrinologists who are out there and practicing in the middle of nowhere, where, we suggest to have an A1C of 6.5. The difference is, when you are in insulin, okay, either your type 1s are always on insulin because they cannot survive without insulin. Type 2s, they may be or may not be on insulin. When you're in insulin, wherever you type 1 or type 2, you have a higher risk of having hypoglycemia. So the lower we aim for A1C, the higher the chances that we may go low. So that's what drives actually our target A1C, whatever is 6.5 versus 7. It is something that will have to be decided with the patient and the doctor, and whole, they should assess all the comorbidities and define a target so the patients know what they should be looking for.
And Malex wants to know, this is kind of a cool question. Throughout your career, you've watched the diabetes epidemic just explode across the world. What do you attribute that to?
The obesity epidemic is one of the biggest factors. When I say obesity epidemic, is the weight gain associated with our diet, inactivity, and that's definitely the biggest contributor to the type 2 diabetes. Right now, out of all the diabetics we have out there, 95% of them are type 2s. And the majority of those type 2s are obese. That means they develop the first insulin resistance. They may have genetics that contributed to it, but eventually, as we get older, as we're getting overweight, and then eventually we're becoming obese, that insulin resistance gets worse, and then we require help with management of our glucose metabolism, eventually requiring insulin. So the obesity is the biggest contributor to the epidemic of diabetes.
Wow. And Douglas has a question. Douglas, go ahead. He's in our live studio audience. For those of you that want to join our live studio audience in the future, email info@padhelp.org. Meantime, if you're watching on YouTube, go ahead and like this video, subscribe to our channel for more great information such as this. We have great people that are joining our live studio audience right now, one by one. But Douglas is here. Douglas, go ahead and ask your question.
Yes, sir. It's great to have you on our program today. And my question, I have been told that I'm on the edge of being diabetic, but does that mean that in the future I'm gonna get it no matter what? Because I have PAD and heart disease, but I'm eating better, I don't smoke, and I'm walking. But does that mean I'm still gonna become diabetic?
Douglas, thank you for having me in your panel. So it does not mean you're going to get it, because we don't know how many years you are in the cusp. But what means is that you have a higher chances of becoming true diabetic. And what matters here is that even when you are pre-diabetic at the earlier phase, you still can get complications. It all comes down to the insulin resistance. Insulin resistance means that the body does not needs more insulin in order to be able to do what it's supposed to do regarding glucose metabolism. So that insulin resistance, guess what? It's responsible also for cardiac disease. It's responsible for PAD, peripheral arterial disease. Is responsible. It creates endothelium destruction and plaques in all major large and small vessels. So you're still at risk of developing cardiovascular disease despite you are pre-diabetic. But that doesn't mean you don't have insulin resistance. You just don't have high sugars.
And for someone who's pre-diabetic, what are the simplest suggestions that you might have for getting that and nipping it in the bud sooner rather than later?
It's all about prevention. If the earlier you start, the better better position you're going to be, because when we start medications, that's already too late. And when we start medications, eventually the cycle of diabetes is, we start metformin. After a couple of years, the patient is not controlled. Then we start another medication. After a couple of years, A1C is trending upwards, and we start another medication. So this is a chronic disease that requires constantly adjustment of the medications, of a dosage of a medication, and eventually new medication. So the earlier you start, the more likely that you're going to regain, or you will have some residual islet cells function. Islet cells are the cells in the pancreas that produce insulin. So we don't want to exhaust those cells. And the best thing to do is if you're pre-diabetic, prevent yourself from becoming diabetic, and take it as seriously as you will do it if you were actually diabetic. Okay, so that's how pre-diabetes is, because that's the best time to intervene to prevent from exhausting your cells that produce insulin, and prevent from becoming diabetic. And what you can do in that case is definitely you have to modify your diet. Definitely you have to become more active. The more active you are, the more likelihood that your insulin will work better, and your insulin resistance levels will go down. And of course, certain medications that can prevent or delay significant the onset of type 2 diabetes.
And Kelly says she's raising some teenagers, particularly teenage boys, and they carb load because they're very, very athletic. And she's concerned that when they get older, that they are going to become diabetic, because as you become less active as you age, you don't need as many carbs. But she's wondering, do you end up continuing to crave the same amount of carbs as you age? What's your best advice for her in guiding her boys as they age?
You know what? That's an excellent question. Yes, the more carbs we eat over years, the more likely that we'll be craving, because think about our brain and it's set up at certain things that we're eating, and we're eating every day. So for years, that becomes a new set point. Now, you don't have to eat carbs to be active and to do weightlifting. Okay. Or go to the gym. You can eat protein. A higher protein, low carb, low fat diet is actually the diet to go. Okay, my son is going to the gym every day, and guess what? He almost has eliminated carbs, which is really not the best thing. You should always have a certain amount of carbs, less than 100 grams, but he eats a lot of protein. Okay, and protein is definitely a healthier way of metabolizing it to a fuel source, so you can be able to do your workouts. So no need to do carbs, but definitely the carb epidemic is what has led to obesity epidemic, and that has led eventually to type 2 diabetes.
Yeah, the misconception that it is the carbs that you need. I remember my brother was a wrestler, and they would always have him carb load before his wrestling tournaments. He would, 2 days before, day before, he would eat nothing but spaghetti and artichoke, spaghetti and artichoke. Like that was his meal. And now we're finding out that while you do need some carbs, it's really the protein that truly, if you use it right, that's what your body actually needs. And we started that with my dad, because my dad is 84 years old, going on 84, and he still has his trainer. He walks 4 miles a day, and he was told by the dietitian, I want you to have a basic protein shake actually in the morning. I don't want you eating a bunch of bread an avocado toast is what he would have in the morning. The protein shakes are better. What do you think?
So, it doesn't need to have shakes, but definitely, shakes are more concentrated and provide you more calories. Just think about this. When we eat a lot of carbs or drink a lot of carbs, because our adolescents drink a lot of juice, a lot of sort of things like that, guess what happens? Your sugars go up. Guess what happens when your sugars go up? Your insulin levels go up. And you're absorbing all this glucose. And eventually you will develop insulin resistance because you're going to get used to a lifestyle that over years requires a lot more insulin than typical to get you to become normoglycemic. So that's why we should not be having a lot of carbs or the way our adolescents are eating or drinking certain beverages during our current situations. So definitely a shake will be something in the for breakfast, like a protein shake, or an egg, or a piece of cheese, or yogurt, anything really that has some protein, because it will help you last more. Breakfast is the biggest and most important meal in the day.
That's interesting. And Kelly came back and she said, should she get a desk for her teenagers to start teaching them early what food does to their bodies?
Kelly has excellent questions because you know what? I've gone through this, Kelly, and what I can tell you the most important thing is with adolescents is education. Educate them, okay? Because we spend a lot of time on social media, a lot. So you get educated about micronutrients, and pretty much you can have them visit a nutritionist who speaks their language and explain to them the difference and explain to them what are the micronutrients, which ones produce more calories, which one's more healthy. So guess what? You're going to win them, and you're going to be able to understand, because then they can go read themselves on the phones or on computers and get important information on how you can get more muscle mass, for example. Okay, how we can lose weight, especially subcutaneous fat, because the body image is also very critical now for adolescents. They want to make sure they want to look good. Okay, so a low fat, a low carb diet is critical.
I would be so excited to see an average influencer who's a teenager start wearing one and making it cool to watch their blood sugar and watch what they eat. I think that would be really cool and trendy. I could almost imagine the benefits of having, wearing that on your arm, being that badge of honor. It's like, hey, I'm worried about my health, right?
Actually, that's a great idea. So when they see the dietitian and learn a little bit about macronutrients and about the diet, and after they do a calorie count, you can explain to them what to expect, and you can put a sensor on them. Okay, and that sensor shows them what happens when they drink. When they eat a Big Mac or they have a big glass of Coke versus eating something that is quite healthier, like a piece of chicken or a sandwich, that doesn't have mayo or on whole wheat. So they definitely learn a lot, and definitely the sensors, even if you're not diabetics, provides a lot of clinical information there that are critical for them to see what's the glycemic value of what they're eating. If they have a very high glycemic value, that means they're more likely that their sugar is going to go up, and eventually it's going to take more time to get down, and eventually that will lead to prediabetes and eventually to diabetes later on.
So I'm just going to put this out there that I think it would be great for the American Diabetes Association to apply for a federal grant to have a pilot program with several schools in their health programs in high school. It's just like there are several health programs that pretend as though someone, they have a baby and they're in a relationship, right? They have those types of classes and they walk around and they know what it's like to care for a child. Like, why couldn't they do this for something that's even more important right now, which is this diabetes epidemic and getting that under control? I think it's the perfect time with the current, with RFK and that Make America Healthy Again movement. Also, the Kennedy Center has grants right now. It would be the perfect project, and I think it would be an easy win with the focus on healthier foods and educating the younger people on what they need to start doing today to protect their future and also ours in our healthcare systems.
Absolutely. The healthcare system should do more. Unfortunately, we're still not in the prevention mode. We're still in the treatment mode. So we treat, and the ADA is really, definitely has picked up the game in terms, not looking only in how to treat diabetes and how also prevent pre-diabetes becoming diabetes, but we really have to focus more on the obesity epidemic and deal
Yeah.
with the what we eating and how we eating, and definitely we need help from all the associations, not just the ADA, because the
Yeah.
ADA is specifically for diabetes, but the Obesity Society, Obesity Medicine, the government, the states, they have to really help provide real nutrition guidance to our, but also they have to provide what healthy food choices in the
Exactly.
school.
I love
Okay.
that Target is going to get rid of all, I think it's artificial colors
Yes.
and chemicals in their cereals, which I think is a really good start. I hope others will follow suit. I think it's so important, especially with cereals being so easy and so popular. It'd be great if all of the food companies could stand up and say, okay, we are committed to the future of our kids, and let's lead by example and start making the changes that we all need to see. It's not just that we want to see, we need to see them. And we have Loretta who's here in our in studio audience. Loretta, do you want to unmute and ask Dr. Manessis your question? Whoops, sorry, I muted you. Go ahead, Loretta.
Hi, I once in a while, maybe once a week, I enjoy drinking iced tea, and I like it with sweetener. And in the restaurant, they have 3 or 4 different artificial sweeteners on the table. And I'm just wondering if any of those sweeteners is safer to use than the others.
I'm not sure if there's really any difference between the sweeteners and how they work, Loretta. It's an excellent question because we like to, as you just said, we like if we are used to drinking our coffee with what? With sugar, it's very difficult to stop what? Sugar at once. So sweeteners should be used from my point of view is as an intermediate states until you really stop, because sweeteners can definitely cause insulin resistance. There is data that supports that. So long-term use of sweeteners are not the solution to eat, feeling something to taste something to be as sweet as we want it. We have to start weaning off even from sweeteners after a short period of time in order to prevent complications associated with how they get metabolized in the liver.
Okay, thank you.
You're
And I'm
welcome.
wondering if Dr. Chen wants to weigh in on the choices that she makes as sweeteners for her own diabetes care. Dr. Chen.
Oh, sorry, I had a little trouble unmuting. Um, I know that I'm trying to be very careful with the sweeteners because some of them, there are literature that shows that consuming it can increase your risk of strokes. So I tend to use more natural sweetener like stevia and monk fruit. So those are my choices. But if I can, I try to wean myself off of things that I don't think are natural and just try to stay away from sucralose and stuff like that. Um, and like Dr. Manassas always teaches the patient during the diabetes education, if you can go like with black coffee, go with that. It'll be better for you. So those are my choices.
And I promise you, you can learn to do it because I used to get a Venti vanilla latte with 4 pumps of vanilla in it. And now I drink straight black coffee. Once I discovered what a really good cup of coffee tastes like, I love the smell of it. I love the rich taste of it. And what really made the difference for me is doing pour overs. So it wasn't watered down. It was really just rich with flavor. So that might be something that you can try. And it's the same thing with iced tea is why don't, I know going out, you don't have much of a choice, but when you're at home, try making some tropical fruit teas, or you can get a really good turmeric ginger tea and then just sweeten it, get a mango tea to go along with it and put it in there. So, and that sweetens it just a little bit. Starts kind of weaning you off of the really, really sweet stuff. But we have another question coming in for Dr. Manessis. Dr. Manessis, Diane wants to know why her doctor would stop an angioplasty procedure because he said that her blood was too thick and syrupy due to her diabetes, and she needed to get her diabetes, her A1C down before he would touch her again.
Okay. Excellent. Great question, because it really brings us to what we see every day in clinical management. So whenever you have to go for a procedure, whatever it's a heart procedure, whatever it is, a procedure for angioplasty for the lower extremities, what matters is, first, because it's invasive procedure, you want your glucose control to be good. Why? Because if your glucose control is high, then there is definitely a much higher risk of infections. The higher the glucose into your bloodstream, the more viscous it is, the less likely those white blood cells will cure the infection. Okay, that may happen. So distally, you're at risk of getting an infection, and because the white cells do not communicate well, they get disoriented when the sugars are high, and also there's a risk. Also, even if you don't have a surgery, an open surgery, but it's really they go from the femoral artery to open and do the procedure, you still have a surgical scar that can get bleed, and you can have a bleeding and infection in that area. The other thing is, when your bloodstream is more viscous with glucose, things do not work out. You have a higher rate of occlusion again, okay? Because guess what? When your sugars are high, your insulin resistance high, and you have the damage of having higher risk of recurrence or forming new occlusions. So that's what we see a lot of times with those angioplasties. So critical control of your sugars, your cholesterol, and your blood pressure is important before you go and have any procedure, okay? It prevents infections, it prevents recurrence, and it prevents also, bad results that we don't want to see, complications associated with those procedures.
And Sfizo, I think, is how he or she pronounces the name, says that they're a type 1 diabetic, but they feel like they're always facing their diabetes because they're up, they're down, they're all around, and they are eating peanut butter toast at night to raise the blood sugar in the evening, and they just don't know what questions they need to ask their endocrinologist, basically, to get some sort of sanity, because they don't think it's natural to be having to eat sweets and carbs, which kind of seems to throw things out of whack. It just is a vicious cycle, is what I think they're saying.
There is a vicious cycles of lows and highs, which is the worst possible scenario in any type 1 or type 2 diabetic who requires insulin. So what happens here in this scenario, patients become low for whatever reason. There's mismatch between what insulin they require and what insulin we give them. Or there may be a mismatch of what insulin they're taking, okay, when they're taking it. Usually we take insulin before meals. If we take insulin we don't eat, guess what? You're going to drop. And when you drop, what happens? You become hypoglycemic. And when your sugars drop, then you have adrenaline hormones. You start having cravings. And guess what? You're going to get scared. You're going to see if it's going low, and you're going to overeat. And that overeating behavior with sugars, with glucose, any glucose-containing products, will lead to very high sugars. And guess what we're going to do after that? I'm going to take insulin when they go high. And when we take insulin, then they may go low again. So it's very critical for, and that's the most important thing here is when you see endocrinologists, make sure that endocrinologist is really an expert in the management of type 1 or type 2 diabetes. Okay, because diabetes is not an easy disease to treat, both at the level of the providers and both at the level of the patients. Type 1s, Dr. Chen has what? Type 1 diabetes for years. And she has really learned how to treat her diabetes better than any other doctors. Okay, why? It's her body. She has no other choice. So it's very critical. And of course, she needs some guidance, and we can provide that guidance. But she reached a point now, being a diabetes educator, where she can provide great guidance to other type 1s who come into the practice. So it's critical to have somebody who really know how to deal with the management of type 1 diabetes in those patients.
Chris wants to know, what's the purpose of an endocrinologist? Because his endocrinologist just brushed him off, saying, if you don't need medication, then I can't help you.
Okay, I assume you don't, Chris, you don't have diabetes?
No, he has diabetes.
And if he doesn't need medication, or if he doesn't want to go on medication?
Okay, no, he said he has a 6 A1C, so he's
Okay,
type 2.
So yes, you have to realize, it's you're very proactive, you're very good, Chris. You really want to prevent what? The diabetes, and you want to do it like we discussed before. You want to be active, and take charge of your lifestyle, whatever lifestyle intervention you can do at the best time. And this is the time you can do. Yeah, the doctor's endocrinologist is not going to see you because unfortunately they're going to say you too easy for them. You too, you don't have, usually the patients that endocrinologists get is some endocrinologists set up points like an A1C above 9. That should not be the point. What should be the point is that you should go see the endocrinologist, and then he can refer you to dietitian, and then you guys can discuss, together with a dietitian or diabetes educator, you can discuss how, any changes you can do in your diet to prevent progression. And of course, there is, you can go on medications to prevent diabetes. Okay, there are medications out there that have the ability of doing that. Okay, if you're overweight, we should focus on losing weight. If you have severe insulin resistance, we should focus on how to reduce that insulin resistance. Okay, because you still are at risk of getting cardiovascular disease or what we call peripheral artery disease. So it really comes down to, I don't see it, yes, we're very busy. I don't see proactivity being a wrong thing. I think it's a great thing to do. But you have to realize, when we are very few endocrinologists, especially in middle of nowhere or in private practice, it's going to be very difficult to find somebody who's going to treat an A1C of 6. But me and you will do it.
He is following up and asking about what is typical in terms of referrals for dietitians for diabetics, even at his level, because he feels as though his primary care didn't have any sort of additional information on referrals. Is that something that he should ask just his insurance company on what's available for programs?
Yes, there's a couple of things he can do. There is, he can ask the primary care doctor if they have any nutritionists that he or she refer his patients, and that will be a very good 1 hour of his time. Primary care doctor can put the sensors that we're discussing to see what meals have raised the sugars and gets them into the pre-diabetic area. That can also endocrinologist can do if they can have time to see those types of patients. Or he can be more proactive and find out from his insurance panel which dietitians take his insurance, and he can set up an appointment.
And this is a really good question coming in from Kimberly. She wants to know what blood tests you typically order for anyone who comes in, even as pre-diabetic or type 2 diabetic. Is there any additional blood work that maybe general primary care would not order or wouldn't even know to order?
It's not they don't know to order, but it's a little bit more outside the spectrum of a practice. So what we do usually is we check to see if there is insulin resistance. Okay, so we check to see what your insulin levels is when you're fasting. The typical thing is also you have to check what are your insulin levels after you eat to be able to really calculate that resistance levels. And depending on the presentation, we sometimes we check antibodies for type 1 if we feel that this clinical presentation is not consistent with a progression in a type 2. So we check the antibodies and we check to see if they're making enough insulin. Now there's other markers you can check for inflammation. And some of the primary care doctors do them. And those are non-specific, but they can definitely provide you information about what? If the insulin resistance associated with inflammation in your bloodstream, which is a sign that eventually that insulin resistance and inflammation can really contribute to what we call plaque formation. Okay. So that's something that primary care doctors can do, and then eventually refer you to be screened by a cardiologist.
I love this as a final question from Lana. She says she's one of the lucky few that was part of a program where she had her pancreas completely replaced. And she wondered, because she tells people all about it, if this is becoming a more standard practice across the US. Or, I mean, I would wonder how long it would take before it is.
Unfortunately, we cannot do that, Lana. That will be a very expensive way of getting a pancreas transplant. But I had in the last 18 years of practice, I'm almost there. I had 2 patients, both of them were type 1s, and both of them end up in dialysis. And guess what? They got a double transplant, pancreas and kidney. Guess what? I saw them once. I spoke to them on the phone after they got the transplant. I haven't seen them since then. They're cured. So yes, pancreatic transplant, transplant of a pancreas is something that really is very difficult and it requires a lot of work. So we should still focus more on prevention than in actually doing something that is very aggressive and very has a high risks. Okay, because
she said she's a type 1. She said she was a type 1 and she had it since she was a kid.
Yes. So
and she said she's so frustrated because even though she did have the transplant, it was a little, too late to prevent the atherosclerosis in her legs.
But at least, you know what? She doesn't have type 1 right now if she got a pancreas. Is that right? If she doesn't have that, that will help her. Yes, we may have some disease, but if you're careful with your blood pressure, your cholesterol, that disease is not going to progress. So guess what? It's still beneficial. Okay. Yes, you went through a lot. Okay. But the fact that you were able to get it, you were able to prevent possible other complications like what? Retinopathy, the eye disease. I don't know if you had a kidney transplant. A lot of type 1s get both of them. Peripheral artery disease, cardiovascular disease, strokes, and things like that. So guess what? In the big scheme of things, if you're able to prevent it or delay the progression, that's a great thing.
Fantastic. And I just have one final question just in the group. Unless anyone who's in studio has additional questions, make sure, raise your hand now or forever hold your peace. Put it in chat or let me know that you want to ask a question. But I'm curious, the dynamic, you have such a wonderful office, you're a practice there. Would love to know how everybody works together with the patients. What's the process for managing your diabetic patients, with you, with Dr. Jean Chen, as well, your diabetic educator, as well as, is it Marina? Marina as well, who's here and joined us.
So it's a team effort. We have, we are certified ADA center, but that doesn't mean anything if you don't have all the different tools nearby. So every patient who comes in goes through the same process. Okay, they see a provider, they get a workup after a good history, and then we put a pads on them, a sensor, and then we evaluate what the effect of the diet has on their diabetes while we're waiting for the labs to come back. And the diabetes educators, specialists are a critical part of that. Okay, why? Because at the same time, they can do a calorie count, they can look at the history, they can look what spikes the sugars, And then depending on how the glucose management goes, then we can decide what would be appropriate medical management.
Mhm.
Then after we see the diabetes educator, we have people who follow them over the phone. Because if they aren't sensors, okay, then they don't need to come in. They can be an hour away and we still can manage them without requiring to come into a practice. And for people who really have to drive hours away to go see endocrinologists, guess what? Remote monitoring is the best thing that has happened in the management of type 2 diabetes. Because the sensors, we can download the data and then we can call you and tell you what to do. And that's what my team does. So we have our team, we have people that helps get the patients a sensor because, the majority, Medicare has specific rules. So and that person who Marina does that actually. And then our team calls up the patients to see how they're doing and make sure they have their prescriptions, make sure their prescriptions are covered, make sure we get a pre-authorization so there's no lagging in time, and make sure that after all that work is done, the patients feel better. And they see the actual hard work they have done since they start seeing us.
Perfect.
It's a team
Jane,
effort.
I love it. Dr. Jane Chen or Marina, do you want to add anything to that?
Well, we also have a few other members of our team here. I see that Catherine's here, Maria's here. Maria is our chief diabetic educator, and I learned a lot from her. She definitely, when I have questions on nutrition, because she's also a registered dietitian, I go to her. We also have nutrition team that we have certified dietitians who actually have advanced degrees, and we also have exercise physiologists who help patients, especially when you are not used to exercising and you're returning to exercise and you have other medical issues like arthritis. You need to work on that carefully and not just cardiovascular so make sure your heart can handle the exercise, but also move you into movement safely. So we have quite an incredible team, and I want to give them the due credit.
Yeah, I would love to just have your team just say hello if they have a second, just to wave so we all can just thank them personally. I think you said there's Catherine and Marina. Just if you can say a quick hello, that would be great. Let me see if I can get Catherine to unmute.
Hey, how are you guys?
Hi, thanks for joining us.
Thank you. Yeah, definitely this is a huge team effort. Without everyone doing their part here on as part of the team, it wouldn't be possible. I'm a pharmacist by trade, so part of my training is the medications, and so our jobs is in between the time of the patient's appointments, where they're coming in every 3 to 4 months. We make sure that every time they come here, they get just a little bit better and better, making sure they have all the tools that they need to get better. And just
Gosh,
keep it
it's
moving.
almost for you like a kid in a candy store. You have so many different options now, and it just seems like more and more every single day.
Yeah.
And I imagine that when with so many different options from Mounjaro to GLP-1s, that it really is a person by person analysis to determine what might be best for their presentation of disease, but also their habits and their willingness to be the best partner in their care.
Absolutely.
Fantastic. Well, thank you everyone for joining us. We really appreciate you. Everyone who's watching, you always have a choice to join our in-studio audience. I'm going to put Dr. Manessis on the spot and say, Dr. Manessis, we got to have you back. Now it's got to be a regular thing. We have so many questions coming in. You're stuck.
I'm stuck, but I'm very happy because you know what? That's what we love doing. We like to help out patients. Our patients, we see our patients as partners, okay, and we are there to help them get better. And
I think that this is so much fun. You were mentioning in the beginning you might be a little nervous. Not at all. You are natural. And we appreciate you donating your time, and especially when so few people have access to an endocrinologist, having you donating your time and being here just to answer general questions. It really helps to inspire people. They feel accountable, and so that they can be the best partners in their care. They feel like someone listens. They feel like someone with the doctor title actually really does care about them. So it really means a lot that you're here and answering their questions one-on-one.
And thank you so much for having me, Kim. Thank you for all the people who are on it, all the patients. And if they have any questions, we can definitely answer them even after the end of the broadcast, because that's our job.
Fantastic. Thank you so much, Dr. Manessis. Thank you, Dr. Chen, and everyone from your entire team for being here, and everyone for watching. Make sure if you do want to be in our live studio audience for the next one, make sure you email info@padhelp.org, and also subscribe to our channel to get notified when we have great content like this, and opportunity